So my name's Chad Sabora. I'm a former drug user, based out of St. Louis. Don't work here anymore though. Spiritually, I live somewhere else. Before my drug use became chaotic, to say the least, I got a bachelor's, master's law degree. I was a prosecuting attorney in Chicago. Then things got a little hectic. Um, and I decided to stop being hectic around 2011. And I did not go back to practicing law, with my lived experience as an attorney and as somebody who used drugs. I had a very interesting perspective on the whole dynamic. So I spent the last 15 years working in probably every facet of this work, from prevention, um, one of the words we can't say anymore, um, treatment, recovery. I innovated one of the first hybrid RCO model, and I've been involved in numerous legislative stuff all over the country. I'm just kind of a nerd when it comes to all of this, which you'll have to excuse my tism a little bit as I go through some things. But this topic has always been something I have been working on actually for years, trying to get some momentum behind it because, the way our peer workforce is set up, the way it functions is not representative of the populations that we're trying to reach. And there's a really simple reason why. So, back in, I think it was 2009 or 2011, I can't recall exactly. There was a big meeting at SAMHSA, where they were putting together what would eventually become peer certification models. And there was a divide, a split in the room, where half of the room wanted to certify individuals. So, individual takes a state accredited course or however it's done in every state, and then they're a peer. And the other half of the room wanted organizations to be the ones to be certified. And then people that worked under that organization would receive training, stuff from the organization. And obviously we know which side of the room won. And there were some very heated debates from the people that were there that I've spoken to. And to this day, myself and many others feel the wrong side of the room won, because when you certify an individual, you lose layers of accountability. You lose the ability to move as things change. And it's much easier to stay on top of an organization when there's not so many. I mean, there's a lot, but then everyone out there in the world that has a peer certification, um, some who are no longer associated with orgs, off running, doing their own thing. It can be dangerous, and our own lived experience can be our worst enemy. So the future of peer work needs to move beyond abstinence, gatekeeping, and these certification rules, which are state specific, but are highly disproportionate to the actual landscape of people who use drugs. Okay, and the peer workforce is expanding. So all states, tie the legitimacy of your job title, your ability to work, in some certification structure that we have no say so in. Um, Most of the current standards were built around recovery. If I can move this a little bit here. Oh, oops, what I do? Sorry. Were built around recovery. When I say recovery, I'm talking, 2009. Although multiple pathways are part of, you know, you know, SAMHSA's and the government's definition of recovery. Back then, we know what they were talking about, and we have to understand that this system was built by a bunch of old white people. And public health realities are evolving at a rate that's much faster than our workforce policy and development changes. We don't adapt to change well. So there's a mismatch amongst this system. People that are at risk for substance use, and the fact that the system fails to recognize so many people as legitimate peers. You only really become visible and certifiable and employable in this position after some personally catastrophic event, a diagnosis, a treatment episode, an arrest, an overdose, that triggers your legitimacy. And that needs to stop. You do not need an outside force to trigger your legitimate lived experiences. And that's one of the biggest messages today. So, since I know some of the people in the chat, I'm going to try to fly through because I do have a lot of slides. Distinguish between substance use and substance use disorder. Talk about why many peer certifications exclude the largest portions of the population. And then we talk about how workforce systems confuse recovery identity with competency. Identify the difference between lawful off-duty, off-work conduct and workplace impairment, which is a huge issue, and discuss some competency-based alternatives to pathway-based workforce standards that don't violate or affect people's decisions or what they do when they're not at work, and evaluate some practical reforms to modernize the peer workforce. Okay, here's the mismatch. Substance use exists across a broad continuum. Most people who use substances do not meet the criteria for a diagnosable substance use disorder. I don't have my presentation version up. Let's see if I can do that real quick so I can see the slide in front of me. Can everyone still just see my PowerPoint the way it was?
Can everyone see it? I think we can. We can't. I
I mean,
can't.
I changed to view so I can see my next slides. Okay.
Yes, we can.
Cool. Okay. So peer certification systems narrowly recognize this abstinence recovery framework tied to diagnosable disorder and some formal recovery identity. Um, and that is that event, that triggered event that makes you unemployable. So it's almost the equivalent of like, getting a degree. You have to have that event in order to be employable. And that's just not how the world works. Because substance use exists on a continuum, on a spectrum. We have a guiding book that tells us this, the DSM-5, because there's mild use, which is your low risk, experimental, recreational, episodic, where you're not meeting 5, 6 or more of DSM criteria to get a diagnosis. And then you start to move up the spectrum to self-medication, chaotic, high-risk use, and, clinically diagnosable. Substance use is one of the only mental health issues, and I don't say disease, it's a mental health phenomenon because we're all different and we all have different reasons why we self-medicated or for things to happen. But it's the only disorder that is not nationally and internationally, even from its own community, recognize that it exists on a spectrum. All diseases, mental health or physical, exist on a spectrum. All recovery from diseases exists on a spectrum, except this one. And that's not, I mean, it does exist on a spectrum. And that's what we have to talk about. It's the fact that, if you can see my little cursor, this is the only group that gets to be peer certifications. This group doesn't. This group represents the majority of people who use drugs, the majority of people who need somebody to talk to, the majority of people who are at risk, the majority of people who are just as important as the minority who develop substance use disorder. So, about 296. Now, the World Health Organization did a study in 2017 and 2021. I couldn't find the 2017 study, but it did show that out of the 296, million global drug users, only 87.3% did not develop enough of those, criteria to be diagnosed with substance use disorder. So, um, so out of the 296 million, approximately, 39 million have SUD. So where are the peer support staff, cultural competent individuals, the similar lived in experience for the 250 million people? They're not there because our certification process does not allow for those people to be represented. And I can't say this with accuracy, but based on how toxic and dangerous our supply has become, the 250 million people that do not have competent representation or peers they can reach out to are a good majority of the people that we are losing unnecessarily, to the various adulterants and increased dangerous supply that we have because we won't recognize access to a safe supply as a solution. And then NSDUH recognizes the same pattern in the United States. So, in the United States, of all the people who are using psychoactive, mind and mood altering drugs, 14% will develop a disorder. So that means we are failing 86% of the population with our current system. The population who uses substances is larger than those who meet the clinical diagnostic criteria. It always has been, it always will be. So we have this broad population that we don't recognize. We don't certify peers that have similar lived experience, and we're not doing anything for them. And my question is why? Okay, because many of these people still face risk of overdose, fentanyl contamination in counterfeit pills, other things. They avoid honest healthcare conversations. That's a huge risk. There's such a stigmatized issue not being recognized or self-identifying as a person who uses drugs, that they're not having honest healthcare conversations. But you know who they would have honest conversations with? A peer, somebody who, is at the same education level, probably the same use level, non-chaotic, non-problematic, you know, um, those people would be able to connect and help individuals navigate the healthcare system, which has become increasingly impossible. So many, even though we have protections, you know, if you go to any of the, what do we call them? Recovery supportive workplace environments, that peer, that system that's set up there, that's not set up for the 87%. That's set up for the 13%. So you have people who are occasional users, not diagnosable, no, they didn't have that catastrophic moment. They can't access those employment resources. They're not for them. So they're excluded. Um, Many never enter treatment systems because they don't need them. And they remain invisible until there's a crisis,
Chad,
whether that be
I'm
um,
sorry. So we were discussing this a little bit of your own personal story, right? And the lack of a lack of having a peer involved. You can
yeah, that's right. Yeah, I mean, so
explain that.
my stories, I um so graduated law school, took the bar. After I took the bar, uh, from the age of 13 until 26, I can't go back. I was in that very low risk area. The, but after I took the bar, my dad got diagnosed with leukemia, died 5 months later, and then like 8 months after he died, my mom was diagnosed with terminal brain and lung cancer, and she died 18 months after him. So for a good chunk of that time period where I was going through all this trauma and grief, I was using painkillers as a way to self-medicate. Um, I was going to work every day. I was meeting my obligations. The only criteria from the DSM I was meeting was the increased tolerance. So, and the withdrawals, which are kind of in one of the criteria. That's it. Two, I had nobody to talk to. Now, my Um, Use definitely escalated, when pain pills became unaccessible and I got into the chaotic phase. But, for years, I lived in that other space and I had nobody to speak to, you know. Um, who knows what would happen? I don't live in the woulda, coulda, shoulda, but if I did, if there was a system set up for individuals like me, back then, because that's the majority. But again, we look at all these barriers they face. We don't have any way for them to access those because you have to have this catastrophic event. So there's also health risks of low diagnosis. Obviously, fentanyl contamination, medical interactions, your high risk from clinicians, you that 87% of people who are not diagnosable does include injection drug users who are at risk for wounds, especially with sedatives in our supply. They're not going to the hospital. They're, they'll be labeled and shamed. Um, Nobody wants that in their medical records, even if there's, protection. I had a fight for years to get my diagnosis removed because, I've had numerous surgeries since I've been in recovery. And for one or two of them, like I was fused any type of painkillers. I can get them now after surgery, but I had a fight and I'm a different person back then. It's been a long time since my parents died. I have no desire to self-medicate that grief and pain anymore because it's healed, So when I've had those times I've been hospitalized or surgeries, taking my painkillers as prescribed, put them down and no thoughts whatsoever. But unless you fight to get that off your record, that label follows you your whole life. And it's different every time you go to the doctor or the ER. And nobody wants to do that, so they're not going to get these wounds checked out. Health avoidance caused by stigma. The risk does not suddenly appear at the moment of diagnosis. The risk is there for lots of reasons, and there's nobody to reach out to. And that's from the CDC overdose prevention report and NIDA. Institutions visibility threshold. So again, we're getting back to the same main point. That's what I had like 35 slides to say the same thing. The public systems only deploy services after diagnosis, arrest, overdose, hospitalization, treatment entry, or criminal legal involvement. That's when peers get deployed. The system often responds only once a person becomes administratively legible. I mean, if we think about this in those terms, how ridiculous is that? You have to become visible to the big system, to Big Brother, because of a serious event to be considered legible. So you're not only labeled, you have to get labeled to become legible. It shouldn't work like that, because in this under this visible threshold is that 87% hidden population currently experiencing risk. The cost of this blind spot is the absence of relatable peers. It's the biggest one. There's no connection. And I said this earlier, there was a point in time, after my dad died, when, if somebody who had their lived experience, now I'll say this, I have put a syringe in my neck in my life. When I was on the painkillers, I hadn't done that yet. And I would not have related to, nor probably wanted to speak to somebody who was coming from that place. So there was no relatable peers. There's, trust me, there's plenty of lawyers, doctors, professionals, you name it, that recreationally use drugs. But I had no access because we don't create that. The fear of stigma, healthcare avoidance, and the escalation of preventable harm, the spread of diseases, and the increased overdose vulnerability, all because we ignore that 87% and we administratively wait until you are diagnosed and legible. Stigma drives non-disclosure. We've kind of talked about this before. We hide information from our employer, from our families, from our healthcare providers, all because we don't want to be honest. Because, and I've experienced it, and I'm sure people, listening have experienced this. We've at some point, most people are people who use drugs, you know, um, and that's okay. That should be okay to admit, but the stigma behind it is so severe that we don't. And I'll say this, if you look at the DSM, nowhere in the clinical criteria does it say the um, schedule or legal status of a substance has anything to do with whether you're diagnosable. Makes no difference whatsoever. The legal status of a substance is subject to the whim of the DEA and the profitable interests of venture capitalists. That's why substances get scheduled. But they're no part of a diagnosis. See, honesty improves safety. If we could be honest, we could improve safety for everybody. But we live in this society where there's punishment is just there, and it suppresses our true. I'm sure all of us have this feeling of being honest about what we do, how we feel, but we live in this construct where that's punished. Truthfulness, honesty, self-awareness, whether it be about drug use, sexual preferences, orientation, gender, it all gets met with punishment. So we hide. And we have to remember peer work originated from mutual aid. And where's the mutual aid for these individuals? It's not there. So, mutual aid communities date back to, pre, the Civil War era, and I harp on this a lot, am I allowed to say harm reduction? I don't know if like with the federal, okay, harm reduction did not start in the 1970s in Rockingham with the junkie hunt. It just did it. You got a bunch of, pale skinned, people in Europe that started the syringe program. It's awesome. That's the deliverable service of harm reduction. Read the pillars. Show me where it says syringe program. Now it can be defined under one of the pillars, but I can go back to the 1600s with the doctor that discovered that the dose equals the poison. Same thing that can cure can be the same thing that heals. That's under one of the pillars. I can go back to Chinese American female doctors treating immigrants who were being disproportionately targeted for going to opium dens, only caring about well-being and not about the arresting of their use. That's under the pillars, and that happened in 1908. And I mean, I could keep going. And those who know me know I can. So we got to understand that our historical roots go back 150 years, and it was mainly led by women of color and minority women. They built this, and we've whitewashed it into some program in the Netherlands in the 70s. Got to stop doing that.
Do
Peer
you
work,
see,
mutual aid. What was
do you
it?
see Aaron's question?
Oh,
You don't? Okay.
I don't see a question.
Okay, I'm going to read it. When I first took recovery peer support coach training, CCAR, in 2009, it seemed like it was meant specifically for people in recovery to help others in recovery in non-clinical settings with their community. There was nothing clinical about it, and it was meant more of the purpose of improving a person's recovery capital, no matter where they were in their journey. Since then, I have seen recovery coaching shift towards getting people into treatment, post-treatment support, and hospital settings, mostly through expanded funding streams for peer support. Can you talk about that shift of non-clinical support within clinical settings has helped or hurt the original role of peer coaching?
I would have to, Aaron, that's a great question. Can we put that in the parking lot? And because it would take me a minute to really process that. It is a great question. But I don't have that much time. You know, um, See, I don't even agree with like how it was started with, improving a person's recovery capital. I would I would shred everything. So I can talk about, you know, I would have to look at, and I would also have to look at data to see if the shift of non-clinical support with clinical settings has helped or hurt. I don't know, but also everything is so individualized that we need to be open-minded. So let me think on that. Um, Mutual aid started mental health consumer survivor organizations. They started urban survivors groups. They started sex worker groups, HIV advocacy groups. All this birthed from mutual aid. Um, and peer support originally centered around shared experience, not clinical conformity and not some state regulation. So we've kind of like, and it's not our fault because we see it happen all the time, but like this this system of peer support predates, you know, adoption by states, recognition as legitimate employment. But we then we run into, the fact that we live in a capitalist society where this social um, safety net has to be funded, so there has to be involvement in this with the state. But this is what happens when things get colonized and co-opted, is they get turned into an agenda, and their agenda doesn't care about the 87%. But just remember where we came from and where our history comes from. Aaron, this might answer your question. Formalized brought medical immigration, billing requirements, state credentialings. No, this won't help your question. So it brought really some pretty good things. We were able to build Medicaid, get some credentialing, we get some oversight, we get to integrate some medical services, have referral systems set up. But it also brought in gatekeeping, clinical assumptions, abstinence-centered legitimacy, and pathway policy, coverage, language policy, all that kind of gatekeeping stuff. So the question is like, do the pros outweigh the cons? I would say no, they don't. I think currently what we're seeing is turning more towards detrimental than helpful, especially as long as if we stay on the path that we're on right now. Okay, cool. First finds Aaron. Okay, what time is it? Oh. So certification narrowed our mutual aid concept. So mutual aid was based in so many things. One of my favorite mutual aid heroes, her name was Madam Stephanie St. Clair, and study her because she's just wow. I mean, I love her. So she was like the queen of the Harlem Underground during the Harlem Renaissance, created the underground banking system because back then, people of color couldn't put their money into banks. They weren't allowed to. So, she helped create the underground lottery and different, policy banking for individuals in Harlem. Um, because economic stability is a social determinant of health. It's part of recovery capital. And that's up here that definitely took it to a whole new level. Even after Prohibition ended, and the other families, now New York families and the other boroughs, they weren't making money anymore, and they tried to move into Harlem. And like Madam St. Clair stood up to Dutch Schultz, and that takes a lot of courage, especially if you think about the gender dynamics, in America in the late 1920s. And, she built that entire um, Harlem movement up and sustained it. Is there, Megan? I didn't know that. On Netflix, I'll have to check it out. Never seen that, just read everything I can about her. So she eventually kind of like moved into policy work, but what she built got turned over once or twice, and then ended up getting turned over to Bumpy Johnson, who's and Frank Lucas was Bumpy Johnson's chauffeur. So we see that pathway of mutual aid going all the way back and how it kind of follows, our own stories here. Um, Booze, bets, and sex. Okay, I'll check it out. Thanks, Mike. But now that certification began, everything got narrowed down. All that stuff that we needed got cut away because it didn't fit into the narratives. Systems began confusing one pathway with the standard. Okay, recovery identity and role competency. It's a huge difference. So we're moving towards conversations about workforce, like guidelines and stuff. So recovery identity is your personal pathway, your valued experience, your individual story. Meg created storytelling, can do one of that. And it's one form of lived experience. Role competency is much different. Ethics, boundaries, communication, safety, reliability. A personal pathway does not determine workforce competency. You may have this and an amazing recovery identity, but you may suck at this. And we see that. We do see the competency issue come up in the peer workforce. We see the stigmatizing of multiple pathways from people who are certified peers. We see the bashing of people involved in, you know, um, alternative forms of employment. Um, and that's not competent work. That's not the ability to support others effectively. You will never support somebody else by tearing down how they choose to live, their self-directed life, as long as they're not causing harm to others. So these two, they don't mean the same thing. You may have that recovery identity that they're looking for, that visual thing, that catastrophic event that makes you visible, legitimizes you and stigmatizes you, but you may not have any of these, but you're still employable. Okay, so workforce policy around abstinence supremacy. And this is a failed test, not even a test, it's a failed, vision. It confuses pathway with competency. It excludes people closest to the current risk environments. It punishes honesty and reoccurrence because you're fear of the job loss. It erases large portions of the population and treats one recovery narrative as universally superior. You cannot say you support multiple pathways, yet fire people unless they're following one pathway. Those two things cannot coexist. Okay. Abstinence is a great, valid pathway. Go for it. It's not supreme. And it creates a flawed workforce and a flawed workforce environment. Competency should be the standard, just like any other job, because this is a job. We don't treat it like one. We treat it like almost like a novelty. Are you competent at your job? Can you maintain boundaries? Can you communicate ethically? Can you support others safely? Can you function without supervision? Can you separate your personal beliefs from peer support? Can you perform your job effectively? If you answer yes to those questions, that is the workforce requirement. It's measurable, not ideological. And currently, our competency for workforce, eligibility and continued employment is rooted in an ideological belief. Okay, so we have to distinguish lived and lived experience because they're both valid and they're both hugely important. Obviously, lived past personal experience, living current experience. The most important individuals right now. Recovery experience, experiencing pursuing recovery, role competency, ability to perform. These are all separate things. Lawful off-duty conduct versus workforce impairment. So let's have a conversation because we all and I can say his name because he's been very open. We all love Merck and we know what happened to him. You know, um, no other job, does this happen. Okay. Not automatically disqualifying. Awful off-duty substance use, prescribed medications, non-abstinence pathways, and recurrence without role impairment. If any of those things happen, that should not cost somebody their career and their livelihood. Yet in the system we have right now, it does. We do have actionable concerns, on-duty impairment, unsafe practice, boundary violation, confidentiality breaches, and ability to perform essential duties. Take away the job title and the system we're in, They get you fired from most jobs. Why aren't we treating this like a normal job? Because what happens on the left is the reason people get fired more than what happens on the right. But I don't know if my slides are backwards. The blue and the orange. And then punitive systems create secrecy. Workers are going to hide a reoccurrence of use because they know they're going to get fired. Workers avoid asking for support. Supervisors receive less accurate information. Fear replaces honesty, and risk escalates the underground world we live in. Supportive supervision improves safety more effectively than punitive exclusion. And we live in a punitive system. As much as we want to say we don't, we do. Our recovery peer system is a punitive system, not towards the people we help, but towards each other. And we wonder why it's toxic. It's rooted in a system that punishes people for doing the same thing that we're supposed to be preaching, which is acceptance of multiple pathways, understanding that a reoccurrence is not a return to use, understand that most people do have the ability to resume controlled use of illicit substances after a period of extended sobriety. That's the majority. And they will be fired for living what the data says is the normal life. The MOUD double standard, oh, we love MOUD. No, most of the time they love naltrexone because it's not an agonist. But many people on MOUD are still stigmatized. I know that New Jersey is very MOUD friendly, but there's other states where very stigmatized, where you're the only peer working there who is on methadone, if you can access it, or who is on you think you're treated the same? You're not. And there's peer systems that treat, peers on medication with less legitimacy, which is absurd because legitimacy is about how well you perform your job, not how you recover. And the contradiction reinforces stigma and exclusion. Evidence-based treatment should not become a basis for workforce discrimination. I think that's all I got to say about that one. Steal that, please. I like that. So you can all steal my shit. It's okay. Okay, the case study. Let's skip the case studies. I want to leave room for questions and conversation. But there's a couple case studies in here, and I don't care about sharing my slides. If anybody wants them, they'll be available. Um, okay, so the counter argument we will face. So whenever you're coming at something like this, like what I do, what I normally do, massive systems change. That's where I live. Art of war. If I don't know my opposition's counter argument and how I'm going to be attacked, I've already lost before I've begun. So you have to identify those. So we already can identify what the counter argument to this proposition would be. And just to be clear, what I'm saying is that in the system that I want, we certify peers at every level of the spectrum: mild, moderate, severe, chaotic. For so basically 4 certifications. Technically, there should be 5, but I mean, maybe overdoing it a little bit because things can bleed over a little bit. And we could probably do 3 and pull this off, but 4 would be ideal. But 4 different certifications, and the important thing with something like this is the deployment of the services, which I can do, which is another presentation, but it's like the operational employment is very doable to make this work and make people be seen and want to reach out and have those conversations and express those healthcare concerns that they can't talk about. But counter argument, this will lower standards. It doesn't remove standards, it shifts them. It shifts standards towards away from the individual's personal choices, what they do when they're not at work, because that's nobody's business. And it focuses on workplace standards of competency, ethics, boundaries, safety, supervision, and performance. We can raise those and still do this. And we should, because, in my opinion, the current standards are not good. People are not held accountable. Way too many people covering for people's bullshit that harms other people and needs to stop. So this would not lower standards whatsoever, because these are the standards, not the other stuff. People currently using substances cannot be peers. That will be a counter argument. Yes, current substance use does not automatically predict unsafe practice because we know the spectrum exists. Workplace safety should be based on observable conduct and role performance. Years ago, unfortunately, it did not get published because we lost the National Harm Reduction TA Center to the defense contractors. But I did write, and this was by the request of the CDC, I did write a toolkit on which was unfortunately never published, on the best practices for the employment of people who use drugs at syringe programs. So even like we have guidelines in place, because there are operational concerns like, driving cars, things I mean, so that's all been addressed by me in the government document that's sitting on somebody's shelf. And it's all workable. Many systems already distinguish status from impairment in other contexts, and you can't have some blanket assumption that just because somebody who currently identifies as a drug user is, under the influence 24 hours a day, because we're not. That 87% that don't develop a clinical diagnosis are not. And just like any other job, if they're impaired when they come to work, people will usually like get written up, get sent home, warning, termination. The question is when this person comes to work, do they have their full capacity? And are they performing their role safely and ethically? They can definitely be peers, even if they identify as drug users. Um, Hell, you can get a freaking DUI for driving after taking NyQuil. So can that person be a peer? Because you can put the same arguments next to each other. And I drive plenty with after I've taken NyQuil. I'm fine. Client needs abstinence role models. No, they don't. Client needs real role models. Many clients benefit from abstinence-based peers. Others don't. Others don't have a desire to reach full abstinence. That's one of our core principles that we've already accepted as a truth, but it's not shown in our workforce development. Different populations require different approaches. Your triple degree, like nerdy individual would definitely require a different approach. And the person who is going to know how to do that approach is that their, doppelganger, their spiritual doppelganger down the street. And we don't know because we don't employ them and talk to them. Representation improves trust and engagement, and one pathway should not monopolize legitimacy, and it does when it comes to the ability to become a peer support specialist. One pathway, and when I talk about pathway, I'm talking about, mental health pathway, that pathway of catastrophe, and that monopolizes the legitimacy of somebody to become employable. And so, do we have a diverse workforce that reflects a diverse population? I don't know. And we need one. And we need to fight for one because they ain't going to give it to us. So, a competence based workforce model, ethics and boundaries, confidentiality, communication skills, cultural humility, safety, awareness, overdose knowledge, all those things. Nobody should ever be terminated. And that's from SAMHSA's national model for peer support from 2023 and from ICIPS for practice guidelines. Does it say like 24/7 sober here? Then why is that a requirement? Why are we firing people, taking away their ability to feed their family? when they're meeting all of the core workforce standards. Blueprint for the modern peer workforce. Separate diagnosis from legitimacy. Measure competency, not some ideology. Distinguish impairment from identity. Lawful, protect lawful off-duty conduct. That's the most important thing. Lawful off-duty conduct is nobody's business. We have to build supportive supervision systems, or that's not punitive, which we have now, include living experience when appropriate, and expand representation across the entire continuum of substance use, and align workforce policy with public health evidence, which is already stated as a requirement. So, you know, public health, the system waits for, diagnosis, treatment, arrests, hospitalization, overdose. Why are we waiting for them to become visible before they become legitimate when we know they're legitimate and we know there's people who need what they have to offer and we're gatekeeping it. So the population is broader than the workforce. There's so many risks below diagnosis. Again, just competency matters more than pathway purity. I can't say that enough. And the future of our workforce depends on whether the field is willing to align the workforce with the observable and also empirically proved reality of drug use. So I'll leave everybody with this because the system waits for diagnosis, treatment, arrest, overdose. What are we waiting for? I know a lot of us can look at this and be like, I'm not waiting, I'm doing that. Good for you. Probably know who you are. Ask this question to others. And contact information there. Thank you for attending this webinar. And thank you and Cara for hosting me and having me present on this topic. For some, it's touchy. For others, I'm sure I said things that you've probably been thinking for years, and I hope that is the majority. And I guess I'll close that, open it up for questions.
Yep. Thank you. Thank you so much for going through all this. It's a lot. It's a lot. I know that, in the beginning with the peer workforce, I mean, we looked at, I know originally they were talking about in order to become a peer, you had to have 2 years in recovery, and that was a big issue that came up for peers going to a lot of the programs that were put together by the state, during using funding. So I think I think that people are starting to understand, the employers are starting to understand that there's questions about what that looks like. So I think this opens up the discussion that there's a lot to talk about. So we're open for any.
Actually, I mean, the two main issues are one, we're only representing 13% of the population that needs us, and B, we're firing people for living their life that we're telling our participants they should live. Those two things don't make sense.